Thank you. Thank you, Dr. Tariq, for the introduction, and I would like to thank all my colleagues, Professor Isa Salmi, and all the colleagues in Oman Society of Nephrology for inviting me today to present this talk. Today, we'll talk about a very common problem in our patients, which is anemia and CKD. In fact, this is not a new problem. This is not a new topic. However, every day we are seeing more and more CKD patients, and anemia is one of the commonest complications in CKD. That's why we have to revise some important data and review the new studies about anemia and CKD. Without delay, I will revise this famous slide. I believe all of you are well acquainted with it, about anemia and CKD. The main cause of anemia is a decreased EPO production by the kidney, in addition to the uremic inhibitors, the bone marrow, plus the high level of hepcidin or hepcidin that is low cleared from the kidney, causing deficient iron stores and availability of iron, and that's cause anemia. All of you are well acquainted with the causes. I will proceed. But what I'm after is a degree or the magnitude of the problem. As you see here in this slide, maybe more than 20 years ago, when the creatinine clearance drops to less than 20 ml per minute, there is a change in hemoglobin, a very significant drop of hemoglobin, and a severe drop of hemoglobin in both males and females when the creatinine clearance is less than 20 ml per minute. So it is very prevalent in CKD, especially the advanced cases. And as you see here in this epidemiological data, that the anemia prevalence in patients with CKD on dialysis is about 87%. And all of us are seeing this in our daily rounds in dialysis units, that almost all patients are more or less anemic. Here, according to statistics, it is about 87%. And the anemia itself can accelerate the progression of CKD by the form of renal ischemia that is also causing a very high cost on the medical services, and it can be a challenging point in the care of patients. Also, when evaluating the magnitude of anemia, anemia further reduces the quality of life, increases the cardiovascular morbidities and mortalities, and it is the leading cause of death. As we all know, that cardiovascular disease is the leading cause of mortality in CKD patients. And also, interestingly enough, that low socioeconomic status and low degree of education of patients are associated with higher and severe degree of anemia compared to high socioeconomic standard. And that's goes without saying, because better treatment and better care in those patients having high socioeconomic level. This slide also is old, in an old study, maybe in 2006, and it shows the impact of anemia on survival of chronic kidney disease patient. And as you see here, as the hemoglobin drops, the probability of survival decreases. And this put to our minds how important is the management of anemia and CKD, because we are talking about improving survival among our patients. Before going into the treatment, I would like to remind you of some basic points. Is that before treating anemia and CKD, please exclude correctable causes. Before rushing into erythropoietin, iron, or any other medications, please remember to exclude correctable causes, such as iron, vitamin B deficiency, iron deficiency, hypothyroidism, hemolysis, blood loss, malignancy. Some cases, such as myeloma, is a cause of CKD and also is a cause of anemia. So before treating the patient with specific medications for anemia and CKD, please exclude correctable causes. When I was a student, the gold standard in treatment of anemia was blood transfusion. And I remember when we are treating patients with AKI or CKD, where it was accustomed to put 1 or 2 units of blood during the dialysis session if the hemoglobin is less than 8. But in fact, this is a very old-fashioned treatment, and all of us know the drawbacks of blood transfusion. In fact, it can correct anemia rapidly, but however, it's associated with high risk of viral infections, iron overload, hyperkalemia, and sensitization to HLA in prospective kidney recipients, prospective transplant recipient. That's why we are discouraging blood transfusion except in emergency situations. Now we'll come to speak some few words about erythropoietin, which is the gold standard in treatment of anemia. And in fact, I recall this old study published in the Lancet 1990 when the erythropoietin was discovered. And this study was conducted only on 10 hemodialysis patients. And the baseline hemoglobin in these patients was about 6. And as you see, they maybe have given a high dose of erythropoietin, leading to a shooting of hemoglobin. And this was a major step in the treatment of anemia in CKD. And after that, many clinical trials have been conducted about different types of erythropoietin, the short-acting, the long-acting, the darbepoetin, the sera. And I believe that you are familiar with these landmark clinical trials, the normal hematocrit trial in 1998, the QUAR and the CREATE studies in 2006, and the TREAT study in 2009. I would like to have to have a glance on one or two of them for some important items. This, for example, is a normal hematocrit trial, which compared the high or the normal hematocrit group versus the low hematocrit group in patients with CKD. And it has been noticed that there is an increased vascular access clotting for these patients having a normal hematocrit level compared to a low hematocrit. And here the intervention group hematocrit is 42% versus the competitor group having a hematocrit of 30%. And also in the QUAR study, those with high hemoglobin has a higher incidence of mortality, stroke, myocardial infarction, and hospitalization. And that's why it has been stopped earlier than planned due to the high risk of clotting and thrombosis when the high hemoglobin target was achieved. We have many types of erythropoietin, and all of us are familiar with them, the erythropoietin alpha and beta, and these are the doses. The darbepoetin may be a leap in the treatment of anemia because it can be given once weekly or even once every 2 weeks with an equal efficacy as erythropoietin, and may be more satisfactory for the staff and for the patient and can be given to outpatients. The same for the sera, which is a continuous erythropoietin receptor activators. And it can be given every 2 weeks or even after 4 weeks. I would like to revise with you the structure of the recombinant human EPO or darbepoetin. This is the recombinant human EPO. It consists of 2 carbohydrate side chains, and this is the erythropoietin receptor, which is a JAK-STAT receptor. And this is the darbepoetin. And only the darbepoetin has some additional carbohydrate side chains. And this is a key factor for the difference in action compared to the recombinant human EPO. All erythropoietins works almost the same by activation of this erythropoietin receptor, which is the JAK2 monomers. When darbepoetin or any other EPO attached to the receptor, there is a receptor dimerization. The receptor dimerization of the Janus kinase system activates the STAT system with the signal transduction action of transmission. And this will lead to gene activation and transcription of regulatory factors for red blood cell formation. This is a classic form of erythropoietin action, whether darbepoetin or recombinant human EPO, the short-acting, or even the sera. But here the darbepoetin has some potential advantages over the recombinant human short-acting EPO, is that the carbohydrate content prolongs its half-life, and the binding affinity for the receptor is astonishingly less. It is 4.3-fold lower than of epoetin alpha, and this is in fact an advantage because the half-life of darbepoetin alpha is longer. Therefore, it is available to bind to, activate, and release the erythropoietin receptor. So it binds to the receptor and then release, and then binds and then release. And this in addition to the long-acting effect, it will lead to fewer doses needed compared to epoetin alpha or beta. And that's in fact more convenient to the medical staff and patients. Most patients receiving darbepoetin are receiving only once weekly compared to the 3 times weekly of epoetin alpha and beta. The same, in fact, for the SERA, or the continuous erythropoietin receptor activator that was registered in 2007. It has even a longer half-life, approximately 130 hours, and can be given once every 2 weeks for the treatment of anemia, and even once monthly for maintenance in dialysis patients. However, most of the studies done for the SERA were non-inferiority studies compared to other erythropoietin stimulating agents. This is one of the famous studies in the non-dialysis CKD patient with the ARCTUS trial that compared the SERA versus darbepoetin alpha for 24 weeks of treatment. So the hemoglobin target of both of them were almost similar, and they concluded that the analysis showed that SERA once every 2 weeks was as effective as darbepoetin alpha once weekly for correcting anemia. So darbepoetin and SERA in this study showed almost equivalent results. In dialysis patients, hemodialysis and PD, I picked this study, which is the AMICUS trial in 2007, which compared the SERA, the continuous erythropoietin receptor activator, to epoetin, and also it was not inferior to erythropoietin, short-acting erythropoietin, regarding the hemoglobin response rate, and thus SERA was not inferior to erythropoietin beta. So let us revise in short what KDIGO says about the ESA. The ESA therapy, the KDIGO recommended for CKD non-dialysis patients with hemoglobin concentration more than 10, we should not start erythropoietin. However, the level of evidence is not strong. It is 2D. And for patients on dialysis stage 5D, they suggested that we start ESA therapy to avoid hemoglobin drop less than 9. So a good starting point is between 9 and 10. And they also suggested that ESA therapy is not usually to maintain hemoglobin above 11.5. And in fact, this is our practice. In our local practice, we usually target a hemoglobin between 10 and 12. Also, I believe the European best practice guidelines are recommending from 10 to 12 grams per deciliter. But they highly recommend it. This is a level evidence 1A, that please don't let the hemoglobin reach 13 grams per deciliter. And this is a high evidence recommendation. Which EPO should we use? Anyone. Anyone can be used, but based on the pharmacodynamics, safety information, clinical outcome data, and cost. Cost also is to be considered. And one of the points I have learned from daily practice is that you choose a EPO which is convenient for your staff and for your patients. If an outpatient or a PD patients, pick an EPO that can be given once weekly or two doses per month, better than a short-acting EPO. In dialysis patients, maybe they are a bit similar, but for the convenience of the staff, we also prefer long-acting erythropoietin. Those on hemodialysis, hemofiltration, hemodiafiltration, intravenous and subcutaneous administration are suggested, but those for outpatients who are not on dialysis or PD patients, they suggested the subcutaneous administration. And an interesting point that adjuvants to erythropoietin therapy are not to be used, such as vitamin C, vitamin D, vitamin E, folic acid, L-carnitine. I remember that L-carnitine at the time took the attention of many nephrologists that myself was against, but I believe the KDIGO also did not recommend the use of L-carnitine, vitamins, and pentoxifene. Please remember that some patients are EPO resistant, and this is by definition receiving more than 450 international units for short-acting EPO per kilogram per week when given IV, or 300 when given subcutaneous. Please search for the cause of EPO resistance. It is not wise to increase the dose of EPO without searching for the cause of resistance. And these are the common causes of resistance, including inflammation, cause inflammation may raise the level of hepcidin, causing iron functional iron deficiency. Iron deficiency itself, hyperparathyroidism, which is quite common in our patients, bleeding, malignancy, drugs, and vitamin B and folic acid deficiency. So please, APO resistance should be put in consideration. I like this paper published recently, maybe a few years back, and they said about that these patients difficult to manage anemic patients. I like this term, difficult to manage anemic patients, and they detected that this group are difficult to manage: anemia of inflammation, type 2 diabetes, cancer, patients who are hospitalized, and some kidney transplant patients. And this summarizes the effect of inflammation on APO resistance. Also, I return back again to hepcidin, lead to diminished release of iron from the reticuloendothelial cell, in addition to the inflammatory mediators, including interferon, interleukin, tumor necrosis alpha, and others. And maybe there is a chance for the hypoxia-inducible factor stabilizers in these patients, and I will get to this later in my talk. Now I'll shift to the iron therapy, and in fact, there are some new data about iron. So maybe about APO, there was not too much new evidence about it, but I would like to talk a few words about iron. And all of us know that iron is absorbed via the DMT1, which is the divalent metal transporter 1 in the intestine, and is released to the blood via the ferroportin, and it binds to the transferrin to reach the red blood cells. And also here the slide shows the inflammation that the hepcidin will block here the ferroportin. This is a hepatocyte, and also it has a very important role in iron metabolism because it releases the hepcidin, and this one will be a big challenge in treatment of anemia. There are two types of iron deficiencies: the absolute iron deficiency and the functional iron deficiency. The functional iron deficiency in patients with inflammation, and the absolute iron deficiency in patients having severe iron deficiency. First, to start with the assessment of iron with the transferrin saturation, the reticulocyte hemoglobin content, and in fact, this is not available in all laboratory. However, usually we depend upon the TSAT and the ferritin level. Interesting study I would like to mention is the pivotal trial, and it compared because we ask usually ourselves which target of anemia of ferritin and transferrin we should reach. Is it a high level of ferritin or it is a low level of ferritin? And in fact, the pivotal trial compared the proactive treatment of iron versus the reactive treatment of iron. Here they withhold iron only if the ferritin level is more than 700 and transferrin saturation is more than 40%. However, the reactive are achieving a low dose iron with a less low level of ferritin and transferrin saturation. And as you see here, the mean ferritin level is in the proactive group was about 600 to 650, while in the low dose iron was about 200 microgram per liter. The cumulative EPO dose in patients having high iron dose was less. So there is a median monthly dose reduced by 19% if you if you achieve a higher ferritin level. So this is a very interesting point. If you give a good amount of iron, if you replenish iron stores, you will need less EPO and less side effects, by the way. What about the outcome regarding the death, myocardial infarction, stroke, heart failure, and hospitalization? In fact, the patient with proactive high dose of iron has less strokes, less myocardial infarction, less heart failure, and hospitalization. And this is a very interesting finding. The only concern is the infection risk, because usually iron treatment is usually linked to high rate of infection. However, this study showed the opposite. There was no significant difference between the high and low iron treatment regarding the infection or hospitalization due to infection. So the infection rate was not high in patients achieving a higher level of ferritin. And they concluded that a proactive higher dose intravenous iron protocol did not affect infection incidence in a large hemodialysis population. The other interesting study is the FIND CKD trial. The FIND CKD trial compared the intravenous compared to the oral iron. The intravenous compound here, they received two targets, ferritin target of 400 to 600, or a low serum ferritin target 100 to 200 compared to oral ferrous sulfate 200 milligram iron per day. And as you see here in the FIND CKD, also there are patients having a high serum ferritin when receiving intravenous iron has a less degree of complications, better anemia treatment, and low dose erythropoietin needed. And he concluded they compared with oral iron, intravenous iron targeting a ferritin is a ferrous carboxyl maltose. Targeting a ferritin 400 to 600 quickly reached and maintained hemoglobin level and delayed or reduced the need for other anemia management, including EPO. Here comes a question, should we give EPO with or without iron? Because some of our practice will give both of them together, but I believe we have to correct iron first because ESA therapy is much less effective in the presence of iron deficiency, requiring higher doses and higher costs. Also, the iron supplementation would appear to be generally safer than erythropoietin. Many patients with iron deficiency will have a significant improvement in the anemia with iron therapy, even without ESA therapy. And finally, please give the IV iron in dialysis patient. I know that KDIGO has some recommendations that you can try oral iron in patients not on dialysis, but in clinical practice, this is usually not effective. These are the old agents in iron therapy: iron dextran, serum ferric gluconate, and iron sucrose. And the iron sucrose, in fact, has the least incidence of anaphylaxis in these components. However, the ferric carboxyl maltose that was mentioned in the previous slide studies maybe has less anaphylaxis incidence. This interesting paper was published in 2021, discussed the recent and emerging therapies for iron deficiency, and I advise you to read about it. It compared all the oral and intravenous medications, and then see this is an interesting component, which is the ferric citrate, which is in fact also a phosphate binder. But as you see here, the cost is very high compared to ferrous gluconate, ferrous fumarate, and the commonly used ferrous sulfate. This is the oral iron preparations. This study showed that ferric citrate as a phosphate binder, in fact, reduced serum phosphate and at the same time raises ferritin, decreased the need of intravenous iron, and decreased the need of erythropoietin. And this might be attractive to nephrologists to give one drug to treat hyperphosphatemia and iron deficiency. However, another opinion may point to use of ferrous sulfate plus calcium acetate or sevelamer or any other agent for phosphate binding. The newer intravenous iron preparation includes ferrimoxitol and the ferric carboxyl maltose, which is the most famous, and the ferric derisomaltose. They are available but not as popular as sucrose, the sucrose iron or the ferric sucrose. But the ferric carboxyl maltose is quite popular in some countries, but they are in fact high in the carbohydrate moieties. And that's a point I would like to mention it about these medications, because these are usually considered newer iron components. But they are linked to what's called the 6H syndrome, because the high carbohydrate moieties, in fact, inhibit the cleavage of fibroblast growth factor 23, which can lead to aggravation or deterioration of the CKD mineral and bone disease. And as you see here, the 6H syndrome consists of high fibroblast growth factor level, hypophosphatemia, hyperphosphaturia, hypovitaminosis D, hypocalcemia, and secondary hyperparathyroidism. I will not go through all of these, but you can revise it in this paper. These are all the pros and cons of intravenous iron, but we are using, in fact, in our daily practice, the iron sucrose. It has a low risk of severe hypersensitivity and low risk of the 6H syndrome, and also it is relatively cheap. The carboxyl maltose also has a low incidence of hypersensitivity and good results in clinical trials. However, the risk of 6H syndrome and the higher cost make it less attractive. The meeting of the KDIGO group, in fact, raised some controversies in iron therapy because now they consider the serum ferritin is not only reflecting the hyperferritinemia, and that hyperferritinemia is not synonymous to iron overload. Some patients may have high ferritin level, but they are not iron overload. And the most important point is the high transferrin saturation in addition to the high ferritin level. So when you find these together, in fact, your patients is iron overload. I'll skip this because I've mentioned it. But again, I'm mentioning that the hepcidin leads to iron trapping in the macrophage. So please, any incidence of inflammation or infection should be treated before considering iron therapy failure. The final part of my talk, in fact, is about the hypoxia-inducible factor stabilizers. And this is, in fact, the most modern, I don't know if it is the best therapy or not. You can say yes or no. Some of us may say yes, some of us may say no. But this is a hypoxia-inducible factor, which is found in many of our tissues, the liver, the kidneys, the lung, and the heart. And this HIF, or the hypoxia-inducible factor, under normal oxygen tension, is inhibited by the HIF prolyl hydroxylase enzyme that leads to degradation. In patients having hypoxia, or even patients with CKD, or patients having living in high altitude, the degradation of the HIF alpha subunit will not occur, and thus will bind to the HIF beta, leading to gene transcription. The HIF stabilizers will lead to increase the endogenous EPO, increase iron absorption, and reduce hepcidin levels. And this is, in fact, interesting and attractive option because it will increase the endogenous EPO and you will not need exogenous EPO. In fact, in chronic kidney disease patient, there is impaired response to hypoxia. There is a pseudo-normoxemic state. There is reduced amount or reduced secretion of the hypoxia-inducible factor. And that's why patients may benefit from hypoxia-inducible factor stabilizers. And in fact, as you see in this slide, the hypoxia-inducible factor PHIs, or the prolyl hydroxylase inhibitors, acts in multi-targeted action. It increases divalent metal transporter 1 expression, reduce hepcidin, increase transferrin, increase the expression of transferrin receptor and the EPO receptor, and the most important is the increase of endogenous EPO. In fact, those who discovered the HIF by itself won the Nobel Prize in 2019 because it will not only affect anemia treatment, but it may also affect other disease treatments. However, the HIF itself has pleiotropic effects. It plays an important role in the angiogenesis, apoptosis, the glycolysis, pH regulation, iron metabolism, oxygen, cell cycle. So this is good that you can target many targets at the same level, but also this is bad because you may have a different and wide range of side effects. So there are some potential uses for the HIF stabilizers. Anemia and CKD, our topic today. 6 compounds are approved for marketing, but it has potential use in myelodysplastic syndromes, ischemic diseases, inflammatory bowel disease. Seems astonishing for us, wound healing, sarcopenia of age, and even the SARS-CoV-2. This was one of the leading trials in the HIF stabilizers, comparing one of the famous HIF stabilizers, which is the daprodustat, which is an oral. All HIF stabilizers are oral medications compared to EPO. And in fact, this study, which was published in the New England Journal of Medicine, showed that in patients undergoing dialysis, daprodustat was non-inferior to erythropoietin-stimulating agents, and also regarding the major adverse cardiac events. The interesting point is that they stimulate the endogenous EPO. As you see here, when giving the roxadustat, which is one of the famous HIF stabilizers, the level of the endogenous EPO rises after 8 to 10 hours of administration and then reach a steady state. compared to exogenous EPO administration, which will lead to a high level of EPO at the start and then decrease by the end to reach a close level. There are many studies. I will not go through all of these, but you can revise it. The HIF stabilizers, daprodustat, roxadustat, vadadustat have been tried in dialysis patients, non-dialysis patients, in PD patients, and even patients who on hemodiafiltration. I've picked two studies. These in the non-dialysis patients, the Olympus trial, comparing the roxadustat to placebo. And in fact, there is a high level of hemoglobin, and this shooting hemoglobin may be striking to some nephrologists, and maybe this is discouraging for others. And the Dolomites trial that compares the roxadustat to darbepoetin, and as you see here, almost an equivalent hemoglobin level in non-dialysis patients receiving roxadustat versus darbepoetin. However, this may be discouraging to some patients, to some nephrologists, that it will add nothing more than darbepoetin, except the idea of secretion of endogenous EPO compared to exogenous. This one, the Pyrenees trial, was applied in patients having HIF stabilizers in dialysis patients, and it also shows that the roxadustat showed a sharp rise of hemoglobin, and this is good and bad at the same time, because we usually don't like the sharp rise of hemoglobin in patients on dialysis for risk of adverse cardiovascular events and clotting. Only just 2 or 3 slides more I have. The impact of the major adverse cardiovascular events, and this trial, in fact, was with the roxadustat, and maybe this pooled analysis of 3 trials showed reduction of the major adverse cardiovascular events in patients receiving roxadustat. So, in fact, the data are conflicting regarding the cardiovascular safety in the HIF stabilizers. Some studies are showing higher rates, some others show lower rate of major adverse cardiovascular outcomes. And I come to this point that the safety concerns maybe make us hesitant in prescribing HIF stabilizers in some patients due to thromboembolic complications. The oncogenic risk stays unclear. The pro-angiogenic effects may have a negative impact on the retinal disease or tumor development. Also, the risk of infection, sepsis, and GIT-associated symptoms. So are HIF stabilizer good, or they are bad, or they are ugly? I like this movie when I was a child. And in fact, they are good because they stimulate endogenous insulin, but they are bad that they have some undetermined side effects, especially cardiovascular disease, and they are ugly in some points that may lead to oncogenesis that's still not clear yet. And that's why some of the medications, such as vadadustat, was once rejected by the FDA and was recently, a few months back, was only registered or approved by the FDA. So the FDA also was hesitant about the approval because of the safety points. Also, FDA approved the daprodustat for anemia of chronic kidney disease in adult dialysis patients. This is my final slide. Please make your treatment of anemia as simple as and stepwise and algorithm. Start with excluding other causes of anemia, inflammation, check the CRP interleukin 6, check for blood loss, check for hemolysis and hematological disorders and vitamin deficiency, check for iron deficiency, and treat it first before prescribing EPO. You can pick short-acting or long-acting erythropoietin. However, I am in favor of the long-acting erythropoietin for more convenience, and at the end, the HIF stabilizer. So we have to think about all what's new. Not all what's new is satisfactory, not all what's new is safe. However, it needs more and more work, more and more research. Thank you so much, and I hope anyone have a question. I'm ready for any discussion. Thank you so much.
Thank you, Dr. Fady, for your insightful session. We appreciate your time and detailed information about this anemia and CKD. Now, coming to the next section, and we will delay the discussion to the end of the sessions. We are talking now about Dr. Mustafa Ahmed, graduated from the King College, London, and trained in nephrology at the Walid renowned Middlesex Institute of Nephrology attached to King College Hospital, and at Guy and St. Thomas Hospital, which is one of the most largest transplant center in the UK. He is now working as consultant nephrology in Imperial College Hospital, Wilcare, and other hospital in UAE. Professor Mustafa Ahmed, actually, he's set up the largest private dialysis center before in Dubai. Also, his team would actually make the first transplant in Zayed Military Hospital. Also, Dr. Ahmed distinction of performing the first Emirati APO incompatible transplant in 2011. Also, he's a dynamic researcher too, and he was a leader in many investigations, especially in diamond study in hypertension. Also, Dr. Ahmed, he have a notable research in nocturnal polyuria in elderly and earned recognition from the York Renal Association. Actually, we are happy to have you today, Professor Mustafa. Now you can start, please. Thank you.
Thank you very much. I'm just going to share my slides. Give me 1 second. Right, you should be able to see my screen. It's quite late in the evening, and Dr. Fady has covered a lot of very good salient points. And I want to start by saying CKD is now CKM, cardio kidney metabolic disease. This is a positioning statement from November of last year, where we've recognized the interlink between obesity and inflammation, decreased hepcidin ion absorption. The obesity leads to inflammation, a high CRP, elevated cholesterol, blood pressure, non-alcoholic fatty liver, kidney issues, albuminuria, type 2 diabetes. And this goes on for many, many, many years. And then you get the subclinical heart failure, and then you get the end result of heart attacks, strokes, peripheral arterial disease. And it's a shame that the American Heart Association in inflammation that we recognize did not include anemia in this cascade, because it is the anemia that we know also has significant morbidity and mortality connotations. The KDIGO heat map, again, classifies kidney disease intermediate, low, high, and very high risk. And what's interesting is that the majority of patients are not referred to specialists. They are treated by primary care doctors, endocrinologists, internal medicine doctors, and there's a significant proportion of these patients that have anemia that are not detected, not treated, and not managed. So we need to really be educating our colleagues. And if you look at patients that are in these groups, under 25% or up to 25% can have anemia. When they get to us, over 50% can have anemia. Now, we know the treatment, 4 pillars of treatment in our patients, the RASI, the non-steroidal MRA, SGLT2, and GLP-1 from the FLOW study published in May. RASI, reducing renal progression, 19%. The finerenone, 18%, SGLT2, 30%, and again, 30% with the GLP-1. And all of these agents, especially the GIPs, look to reduce inflammation and fat burden, and those in themselves would have an implication for anemia, for hepcidin, and for improvement in our patients. And that also goes with SGLT2s. I saw somebody put a very clever question about that that we will address later. Pill burden, though, is important. And you think about the number of pills our patients with chronic kidney disease are taking, and that's a very big issue. Adherence. They don't continue taking the medicines. They don't take it regularly. And that's a huge issue with the HIF per hydroxylase factors, the hypoxia-inducing factors, the roxadustat. You're telling patients to give this tablet 3 times a week, Monday, Wednesday, and Friday. Do you know how difficult it is for a patient to give a medicine 3 times a week to themselves? They often ask me, every other day? Why can't I take it every other day? Why can't I take it once a week? And if you look at adherence, we know that 40% of patients stop RASI after 12 months, and only 1 in 4 patients continue GLP-1 after 2 years. So this is some of our local data. 33,000 patients with type 2 diabetes at the Imperial College, and 25% have a filtration rate of between 60 to 90, and just under 7% have less than 60% kidney function. What we are seeing in our population is that 25% of our type 2 diabetic patients have an ACR of more than 3.5 or a microalbumin of more than 30. So we are dealing in this region with a very high inflammatory cohort, the high obesity, the high inflammation, the higher CRP, the higher cardiovascular. And that's very concerning. 1 in 4 of our type 2 diabetic patients have an elevated ACR. If you look at our patients, barely 50% are on SGLT2 and RASI. Again, compliance is an issue. And if you look at the heat map with regard to our patient, you can see that around 2,000 just over intermediate risk, but of high and very high risk, we have over 1,500 patients. If you equate that to anemia, as I've told before, you can see that as you have more inflammation, CKM, hepcidin reduction, higher CRP, you have more anemia. And the majority of our patients, as you can see, are in the treatment bracket before they reach the specialists, before they even reach us. A significant proportion, up to 40%, have anemia. And that is very concerning because it is not being treated in our patient cohorts. These are the high and very high risk on the KDIGO heat map. And I was just telling Fady earlier, the beauty of having interregional speakers is we can share experiences. And again, if you look at CKM risk factors, we're achieving targets in barely 50% of our patients. And I can assure you that is the same for anemia, if not worse, and only 50% and 60% are on RASI. So let's focus on the anemia. Well, again, we know that anemia is a multiplier for mortality in chronic kidney disease patients. And it's very important to take a history. This is not being done by my colleagues. With the 30% prevalence rate, the 1 in 4 having a microalbumin of 33,000 patients. People are not asking them if they've had melena or gastritis. Look for microcytic anemia to suggest iron deficiency or hereditary anemias. The use of aspirin in primary prevention, again, is not being addressed. B12 levels are not being performed, even though the ADA endorses this to be performed on an annual basis on people that have been on metformin for more than 4 years. The ferritin, folic acid, CRP, and the transferrin saturation, of which I think of the 30 endocrinologists, I'm the only one as a nephrologist performing it at the Imperial College. As Dr. Fady said, the ARA, the UK Renal Association, recommend CRP as part of the workup, looking at inflammation in these patients. And again, the AGA, American Gastroenterology Association, 2020 shows that the anemia prevalence increases with age and iron deficiency also increases. The AGA specifically state grade 1A that in postmenopausal men and women over the age of 50, iron deficiency should have a bidirectional endoscopy. This is still, these patients with blatant iron deficiency are not being referred, and I am still picking up significant pathology in our patients. This is the ADA 2024, January, released in December 23 for aspirin. In our group of patients over the age of 50 with hypertension, dyslipidemia, albuminuria, heart disease, absolutely, it's indicated. But in secondary, in primary prevention, if you don't have risk factors and you're younger, then you shouldn't be on aspirin. This is the ADA guideline for B12 monitoring on an annual basis if you've been on metformin for more than 4 years. Transferrin saturation is also very important. Ferritin is not good enough. It is an inflammatory marker. It goes up, and we know with the CRP, with CKM, with obesity, malignancies, other inflammation, liver diseases, really it's not a good marker by itself, and it should be used with the TSAT. And what is the definition of iron deficiency anemia? A ferritin of less than 100 or a TSAT of less than 20. Someone is iron replete if their ferritin is more than 100 and their transferrin is more than 20%. And again, that question was asked. So I want to be very clear. If you've got a TSAT of less than 20%, you are iron deficient and you would benefit from iron replacement. The KDIGO, again, transferrin saturation. The Renal Association, transferrin saturation. The AGA, transferrin saturation. So please, they go together, a ferritin and a TSAT in terms of iron deficiency is what we should be looking at. A lot of places still use iron. Iron has a circadian rhythm, and again, iron is not reliable indication of iron deficiency, really. It's the ferritin and the TSAT. And this was really demonstrated in a lovely paper last year in patients with HUFRUF that didn't get benefit from iron replacement because they only looked at the ferritin and not the TSAT. This was a negative paper, but the editorial was very hard in pointing out the need for us to do TSAT with ferritin. Target hemoglobin, well, again, we know that if you're less than 11 grams, you have an increased mortality. And if you're a longer time coming up to 11 grams, you also have a higher mortality. And in looking at the major published trials for cardiovascular outcome and chronic kidney disease, looking at different hemoglobin groups, they find overall a higher mortality when your hemoglobin is more than 13. So as Dr. Fady said, it looks like the hemoglobin of 11 to 12 grams should be our target. And this is a lovely paper published last year in November, and it looked at people with myocardial infarction with anemia, with and without liberal blood transfusion, showing that it didn't really make a difference. So a higher hemoglobin certainly, again, doesn't always equate to a better outcome, and hence we can keep them a bit lower, target hemoglobin between 10 to 12 grams in terms of the aranesp, the darbepoetin label that exists, and the darbepoetin are looking for a rise of greater than 2 grams in 4 weeks, then there would be a dose reduction of 20%. So we don't like to correct it too quickly, as Dr. Fady said earlier, and if we are going more than 2 grams, reduce by 25% of the dose. That's on the label. So our hemoglobin of less than 11, increased risk of mortality, the longer time required to reach a hemoglobin target can increase mortality, but we don't like to correct it too quickly. And a HB level between 12 and 13 are probably the most associated lower risk, but not more than 13. And we know that the HIF-per hydroxylase inhibitors also look at gene activation, the alpha part of the HIF. However, the erythropoietin stimulating agents also work on gene activation with signal transduction. And that is part of their mechanism that underlies their sustained hemoglobin response. And it's because of this that we now have a license with the aranesp for monthly injection. So not only can it be given weekly on dialysis, it can be given every 2 weeks, but it can also be given once a month. And that's a huge benefit for patients, as I mentioned earlier, that are not compliant, won't take their medicines, have a high discontinuation rate of medications, and are simply not taking. When you are giving an injection, then obviously you know that they are receiving, you have accessory factors, and you will achieve a better target. The half-life of aranesp is long enough to allow extended dosing, but short enough for customized control HB levels when needed. And the variety of doses that we have allow us to adjust to not achieve a higher hemoglobin too quickly, more than 2 grams in 4 weeks, dose reduction of 25%, but at the same time, we like to achieve a hemoglobin of around 12 grams, not less than 11, and not more than 13. And you can achieve a number of administrations from every week, every 2 weeks, and every month dosing now with aranesp to achieve efficacy and hemoglobin targets in our patients and our outpatients in particular. In chronic kidney disease patients that are not on dialysis, hemoglobin again is successfully treated with monthly darbepoetin alpha, reaching a target level in 93% of patients. And again, very much preferred. And this is the experience I have. I have probably over 150 patients on roxadustat, and I have almost the same, if not more, on darbepoetin, the monthly injection, where in a lot of my patients, they prefer this treatment. Less medication, not much more to remember, less compliance issues, better hemoglobin, and again, they know, and I know that it has been given to my patients. So again, this is the study from looking at the monthly injection of darbepoetin alpha, showing the randomization every 2 weeks, every 1 month, for sustained increase in hemoglobin in 340 patients. And they have shown in 150 in each group, comparable hemoglobin levels with the monthly injection of aranesp in the outpatient setting. So very, very important that we do have that flexibility in our patients. And again, looking at these patients, there is a sustained hemoglobin that is very stable with less cycling in this cohort of patients, and a lower incidence of patients achieving hemoglobins of over 13 that we want to avoid. So RNS gives us darbepoetin alpha, a number of flexible choices, both with our outpatients, reducing pill burden, sustainability, target hemoglobin, compliance with patients that are on the monthly injections for our patients. And again, international guidelines are also recommending a hemoglobin of between 11 to 13 grams. 11 to 12 really is what I aim for in my patient cohort. The KDIGO, again, this is the executive summary from last year, and they have shown that they are non-inferior to ESA in maintaining hemoglobin. A lot of the studies from China with the HIF-per hydroxylase inhibitors were really on dialysis patients. And for the life of me, I cannot see why I would give a dialysis patient a tablet when I can give them an injection on a dialysis machine. So none of my dialysis patients are on extra tablets. They are all being administered darbepoetin through the machine. But our outpatients, well, there is a role, and as Dr. Fady said, there's good and there's bad. And from my experience, I find that patients get confused. I find they need more iron, interestingly. So all my patients on HIF-per hydroxylase, even though it's supposed to reduce hepcidin and increase iron absorption, they all seem to need more iron, more ferrous carboxymaltose, which is what I use most commonly, than patients on the monthly darbepoetin. I do find equivalency with the darbepoetin and preference with the patients, but the roxadustat, which is what we use, is also a very good agent, and some patients prefer it, and you can achieve a target, although it does take longer, and you do need to do more of the dose adjustments, starting with a dose of 70 3 times a week, moving to 100 3 times a week if they don't respond. But the biggest hiccup is this 3 times a week. You know, telling a patient to take a medicine 3 times a week, a tablet, seems to be a huge obstacle. And again, adherence and extensive clinical experience with the erythropoietin stimulating agents is important. So I'm going to go on to answer another question that I saw flash up on the screen. How is this all related? Why is Dr. Mustafa talking about CKM, obesity, inflammation, CRP, transferrin saturation? Why is ferritin not good enough? And it's all to do with CKM. It's the inflammation, it's the evaluation. And with our modern medicines, the GLP, GIPs, the SGLT2s, they are all working to reduce this. And this was a lovely paper just published a few months ago. And this is from the EMPA Reg. And the conclusion in this paper is that in those patients that achieved a benefit, the strongest mediator was hematocrit and hemoglobin in patients on SGLT2. Changes in hematocrit and hemoglobin were the strongest mediators in empagliflozin's outcome benefit in patients with type 2 diabetes. So here you go. This is my cohort again, my 33,000 patients, of which I have 50% on SGLT2. That's over 16,000 patients on SGLT2. And what you can see, those on SGLT2 in my cohort were older, they were fatter, they had an elevated, significantly higher body mass index. They had a wider pulse pressure, the distance between the top and the lower blood pressure. They had a lower GFR. So people with a lower GFR were being treated with the SGLT2 quite rightly. They had a higher microalbumin. They had a lower ferritin. So these are very high inflammatory patients. These are the 16,000 on SGLT2. they had a higher sugar level, they had a higher ACR. So these patients are higher inflammatory risk and quite rightly are treated more with SGLT2. But what you see is these patients you would expect to be more anemic, but yet they had a higher hematocrit and they had a significantly higher hemoglobin. So again, this is pointing towards the improvement of CKM and whether we are achieving this through our conventional ESAs in modulating the mortality and morbidity through tissue perfusion, or whether it be nitric oxide improvement of the vasculature, whether it be an independent anti-inflammatory response. These are all linked to each other, and it's really food for thought. Are these agents, the SGLT2s and most likely the GLP-1, I've not done the analysis on GLP-1, but are these agents working and achieving their benefit and mortality benefit through the improvement of hemoglobin? And I come back to the American Heart Association positioning statement for CKM, CKM, CKM. I am disappointed that anemia has not been included. I do believe that there is a huge burden that are not seeing the specialist. We do need to educate our colleagues. We do need to optimize, refer to the gastroenterologist with iron deficiency anemia. We do have options for the treatment of anemia. And again, the more safe, the more studied, and the more convenient tend to be the monthly injections in our outpatient clinics at the moment. Keep the window open for our newer treatments of CKM and their effects on metabolism, and certainly their effects on mortality and morbidity reduction in the future. So I'd like to leave you with that, and thank you for your attention.
Thank you, Dr. Mustafa, for the excellent presentation. I really enjoyed it. And in fact, I totally agree with you that the CKM syndrome should be the most accepted definition of our patients. And in fact, maybe they didn't conclude anemia because they considered anemia as a part of the CKD. And maybe they go hand in hand together or side to side. But as you said, also regarding the new treatments, we should not rush to write them except after showing a benefit than our standard level of care. So we would like to hear from the audience about any questions for me or Dr. Mustafa. You are welcome.
So I'll just go to the chat section here. And again, we've got ACE inhibitors may lead to a slight reduction in HB. SGLT2 tend to raise hemoglobin levels, which have been answered by the speakers. The effects of HIF stabilizers on fibrosis, vascular calcification. Dr. Fady, you mentioned we're still not clear about this. Dr. Fady, are you using the roxadustat in your dialysis patients?
No, not yet registered here in Oman, not yet registered in dialysis patients.
Right.
We are using mainly the epoetin beta and the darbepoetin, and in fewer patients, the sera. But the most widely used is darbepoetin and epoetin beta. Still, HIF stabilizers are not registered for the use of in dialysis patients in the Ministry of Health.
Mm-hmm. Okay, as I say, I can't see why I would give a dialysis patient tablets when I can give them an injection on dialysis. So, but certainly in the outpatient clinic, I would say that there is a role. I don't want to be completely negative. They are effective. I do reach stability. But there is a big question mark on some of the safety issues, which I believe will be cleared up as time goes on.
even the FDA itself was not didn't approve it that easily. It took a time, and they rejected once, and then they approved again. That means also the FDA was not that sharp, clear about the safety of these medications. However, as I've just said, it is good for outpatients and patients on peritoneal dialysis. However, also as a personal experience, patients receiving darbepoetin or sera as an outpatient once weekly or once every 2 weeks or once a month, it is a bit very good. It is convenient to most patients, especially that most of our patients in Oman are diabetic. Maybe the prevalence of diabetic kidney disease as a cause of end-stage kidney disease may be 50 or 60% of our patients. So patients are already accustomed for subcutaneous injections. So they are not bothered that way with the subcutaneous injection of darbepoetin or sera.
Yeah, and again, the last question is, SGLT2 can stimulate the erythropoiesis, improve renal hypoxia, reduce inflammation. So we are doing our analysis now. We've just submitted a paper to NDT, and we're going to be looking specifically at whether we are getting the same hemoglobin effect with the GLP and the GLP-GIP. So is the effect of the hemoglobin and hematocrit with SGLT2 due to the diuresis, or is it due to anti-inflammation and reduction of hepcidin? So I believe we may be able to actually go some way to try and tease out the medical and medicine effects in CKM and their effect on hemoglobin and hematocrit. And the other question is here, what about the role of a low vitamin D level and anemia prevalence in CKD? Well, again, most of our patients have very good vitamin D levels. We haven't looked at that specifically because we do tend to replace vitamin D a lot, even though it's not recommended now. I don't think I'm going to see anything in terms of vitamin D and anemia, but certainly the prevalence in chronic kidney disease in the patients that we're not seeing is quite high. And I believe that there is an urgent need to address not only the low rates of us achieving the usage of SGLT2 and RASI. I mean, RASI, 60% of our patients that are high and very high risk are on RASI. So we do need to be monitoring, following, using RAS enablers, educating more to allow us to achieve our targets. I believe, Dr. Fady, we have an enormous mountain to climb here in the UAE and probably in Oman as well.
Yes, of course. Yes, sure. Any more questions from the floor?
Dr. Mustafa?
Yes.
Yes.
Yes, thank you for your excellent presentation. I have a question for you. When you will consider resistance to EPO, like pure red cell aplasia, while you're treating patient with EPO?
That's a good question. And people that come in with hypertension, a lot of doctors do a lot of tests. They do the catecholamines, the VIPs, they do the renin-aldosterone levels. In my time as a nephrologist, 15 years, how many people have I seen with renal artery stenosis or fibromuscular hyperplasia? Maybe a dozen. How many with Conn syndrome? 3. How many with paraganglionoma? 3. How many patients have I seen with pure red cell aplasia? Probably 1. So I don't see it commonly. And as Dr. Fady said, inflammation undiagnosed paraneoplastic myeloma, but pure red cell aplasia in terms of antibody mediated to erythropoietin, causing the depletion of the cells. Very rare in this part of the world, and I've only seen the one case. I don't know about you, Dr. Fady. Have you seen any more?
No. Pure red cell aplasia, no more. The most famous causes we are having about APO-resistant anemia are hyperparathyroidism and infection. That's the most common we see in our daily practice. Hyperparathyroidism are commonly not properly treated. Many patients are rejecting parathyroidectomy, and a lot of patients are not compliant on calcium mimetics due to the GIT side effects. So the hyperparathyroidism, in fact, the most challenging cause of APO-resistant anemia, in addition to recurrent episodes of infections, especially related to central line infections.
Yeah, that's interesting. Are you using Parsabiv there?
No. We are not using. We are only using the alpha calcidol and the paracalcitol and the cinacalcit. This is what we are using.
Right. Parsabiv has really turned my
still.
cohorts around. I mean, Parsabiv is a fantastic medication with Zemplar paracalcitrol.
Yes.
But yeah, absolutely. I'm really probably one case of pure red cell aplasia, probably. So not common.
I have never seen it.
Okay, can I ask another question? If I have patient on 12,000 EPO 3 times per week and iron stores are adequate, how far I can go with the EPO?
Well,
and the hemoglobin is still low, although you're putting the patient on EPO high dose 12,000 3 times per week, and iron stores are good, adequate. So shall I refer to hematologist? Shall I, increase the EPO?
Well, I certainly would refer to the hematologist, because they may look for any myelodysplasia the patient may have. And given that it's very uncommon both with me and Dr. Fady. Now, I do have a few patients that are on a very high dose, but they maintain a stable low hemoglobin of 8 grams. And I find that if they're stable and they're on a maintenance dose, then I tend to leave them as they are after I've obviously referred them on. Would I keep increasing the EPO if they keep dropping their hemoglobin? Probably not, because of the potential vascular issues and the possibility of us not identifying a mitosis. There will always be a cohort of patients that would need regular blood transfusions. And again, these patients tend to be extremely sick. And I do have a few that I have encountered, but they're on ventilators and, are not stable outpatients. So certainly referral to hematology. What do you think, Dr. Fady?
Yes, I totally agree with Dr. Mustafa. Even in the past few years, we have 4 or 5 patients in one unit that was diagnosed as myelodysplastic syndrome or a hidden malignancy, solid organ malignancy. One of them, I remember, had a cancer bladder. And he was on dual antiplatelet therapy because of previous cabbage. So it was attributed to the antiplatelet, and it turned out to be a cancer bladder. And the other patients had myelodysplastic syndromes. So I totally agree with you, is that if the patient is on high dose of EPO, don't make it too high. If he will not respond on a high dose, he will probably not respond to a very high dose. That's not a wise decision, and I prefer to search for an underlying cause of EPO resistance rather than keeping increasing the EPO dose without any workup. So the malignancy should be put in the priority, especially if the patient is old. Myelodysplastic syndrome is not uncommon, and also hyperparathyroidism, as I've just mentioned. Bleeding also should be, especially GIT bleeding, hidden GIT bleeding, or obscure GIT bleeding should not be neglected.
Thank you, Professor Mustafa. Thank you, Dr. Fady, for this nice and actually elegant scientific day. We learned too much today about anemia and CKD. And thank you, Dr. Mustafa, for emphasizing on the concept of CKM. Actually, this is the right way to assess and treat the patient with anemia. We are happy to have you again next month, inshallah, in collaboration with Amgen for the CKD MBD to start another series with us. Now coming to the last word from the chairperson of Oman Society of Nephrology and Transplantation, Dr. Isa Salmi. Welcome, Dr. Isa.
Thank you very much, Tarek. I would like to thank Dr. Fady and our colleagues, Dr. Mustafa from UK. Would like definitely to thank Amgen for their very amazing contribution and support in education research. And would like to thank all our colleagues who attended today. And as Tarek said, hopefully we'll see you in the coming month as well. Thank you very much.